Okay, good evening, ladies and gentlemen. Welcome to the Medium-Eyes Expo session on subthreshold laser therapy. Thank you for taking time out from your busy schedule to join us. And also, it's a great pleasure to be here with all of you from all over the world. My name is Dr. Kenneth Fong, and I'll be co-moderating this session with Dr. Victor Chong. Before we start our interesting symposium this evening, I'd like to invite Dr. Victor Chong to introduce a new society that we have formed called the Subthreshold Ophthalmic Laser Society. Over to you, Victor.
Thank you very much, Ken. Well, I think that laser has been used in ophthalmology for many, many years. Actually, that it was all about using the laser to destroy a lesion. However, that in recent years that we have found that we actually don't need to kill cells with the laser, but to activate the cell to achieving biological effect. This have really changed the way that we think about laser, and most of this revolution have been started in retina, but more recently in glaucoma as well. However, there is still a lot of misunderstanding of the concept. I hope that this webinar today will answer some of those questions, but there's a lot of things that are still need to develop into the best practice, and because that different people are using the laser differently. The aim of our society is to promote a better understanding of the technology, and so as we can discuss what we know, and also that to work out what we don't know. And initially that this is the first of our webinar, and the goal is to put a central depository of all this educational material into one place, and which will be accessed freely. And we, with the founding member, we have a potential to develop this in multiple languages, including English, Spanish, and Mandarin. So looking forward that this society will grow, and then we'll then take on more members as time goes along. And welcome again to the webinar, and I pass it back to Ken to start the program.
Thank you, Victor. So we have three distinguished speakers who are world experts on subthreshold laser joining us today. They are Dr. Lihteh Wu from Costa Rica. They are Dr. Chhablani from Pittsburgh, USA, and Dr. Alejandro Filloy from Spain. Our first speaker today is Dr. Lihteh Wu, who is a retinal specialist from Costa Rica. Due to the time difference between Asia Pacific and Costa Rica, he has chosen to record his presentation, and we will start with his presentation. And I'd like to ask the administrators to start his presentation. Thank you.
Good evening, this is Lihteh Wu, and tonight I will be talking to you on subthreshold macular laser. First of all, my disclosures. Please notice that I am a consultant for Quantel Medical, which happens to be one of the global ophthalmic laser manufacturers. A few words about nomenclature. Subthreshold just means that the laser burns are not visible, and subliminal is the same as micropulse. Why do we even bother talking about subthreshold laser? The reason is that we want to eliminate iatrogenic damage from conventional macular photocoagulation. Conventional macular photocoagulation is also known as continuous wave photocoagulation. As you can see from these fundus photographs, these patients previously had diabetic macular edema and received conventional macular photocoagulation years ago. Although there is no longer diabetic macular edema present, there's widespread iatrogenic macular damage caused from the photocoagulation. You will recall that during conventional photocoagulation, the surgeon chooses a power setting and the duration of each burn. Once the surgeon steps on the pedal, the desired power is reached and the energy is maintained at that level for the entire duration of the burn. This is a graph that illustrates the effect that exposure times have on the laser burn. We can see that as the exposure times are reduced, there is less lateral heat expansion. With increase in exposure times, then the burn not only burns the RPE, but also starts burning the retina as well. Also, the adjacent RPE is also burned by increasing the exposure times. So one way of decreasing iatrogenic damage is by reducing the exposure times. Another way of doing so is by using subliminal or micropulse technology. Remember that in conventional photocoagulation, once we hit the pedal, the power remains on for the entire duration of the burn. In micropulse or subliminal mode, what happens is that duration of the burn is broken up into micropulses. And then this allows the energy to be delivered only at a fraction of the entire pulse duration, which allows the tissue to cool off, and then there is less chance of inducing macular iatrogenic damage. Remember that subthreshold, subliminal, micropulse treatments are macular treatments. Again, the subliminal or micropulse mode refers to the technology that breaks down the pulse duration into several micropulses. And then this allows that the energy is only on for a fraction of the duration of the pulse. Here we will introduce the concept of duty cycle. So the duty cycle refers to the time that the laser is on divided by the entire duration of the pulse. So when we talk about a 5% duty cycle, what that means is that the laser is on 5% of the time, and 95% of the time the laser is off. And during that 95% of the time that the laser is off, the tissue is allowed to cool, so there is no heat wave expansion. So again, in the subliminal or micropulse mode, there is low thermal diffusion due to the long off time between each pulse. Now let's talk about what an ideal micropulse or subliminal laser, what are the characteristics of them? Well, one, the wavelength is important, and we acknowledge that the yellow wavelength is superior for this. Second, we need that there should be multi-spot technology. And three, that the laser has the ability to provide a low duty cycle. So again, let's review these. Wavelength, does it matter? So here are extension coefficients, and we can see that in order to obtain the best results with the maximum efficacy and safety, the ideal laser should have a uniform thermal effect, good penetration through opacities, and low energy absorption by xanthophyll, which is the pigment present in the macular area. Here, the main chromophores that are absorbing the laser energy are melanin and hemoglobin. And you can see here that the 577 laser wavelength is actually the best because it has a high absorption in melanin and also in oxyhemoglobin and hemoglobin as well, and it avoids the xanthophyll absorption in the macular area. So yes, wavelength is important, and the best is 577 because it also allows us to titrate the power directly under micropulse or subliminal mode, allowing us to reach a visible endpoint. Multispot is important, and here you have the laser cavity and optic fiber that has a scanner coupled with different mirrors, and the laser beam is deflected by two motorized mirrors to produce a pattern, as you can see here. Why is multispot important? Because with multispot, we are able to do confluent laser therapy, and then there is lower risk of undertreatment with the multi-spot. A monospot is very difficult in application because the burns are invisible, so you will not be sure where you put in one burn after you put it in one. So the most common cause of treatment failure is undertreatment. Therefore, multi-spot is important because it assures us that we have delivered the treatment as we wish. In terms of duty cycle, Victor Chong and others have shown that the less iatrogenic damage, at least in rabbit eyes, was caused by using a 5% duty cycle. We have some treatment guidelines, and what we want is a dense treatment, and by requiring a dense treatment, we use large spot sizes. Since there's no intended thermal injury using this micropulse or subliminal mode, we can use large 160 micron spot sizes in order to increase the treatment area and to ensure a dense delivery of the laser impacts. As an example, if we use, for instance, this grid of 25 burns that are 50 microns in size, and we really want to continue using those 50 micron spot sizes, if we want to use a dense treatment, we would require 81 burns. However, if we increase this to 160 micron spot size, we just need to deliver the same 25 spots. So in essence, our treatment guidelines, the settings are the following. We choose a spot size of 160 microns. We use the subliminal or micropulse mode. The duty cycle is 5%, and the exposure time is 0.2 seconds. So these are all fixed settings, and we recommend using a laser lens that has a magnification of approximately 1, and the one that I prefer using is the Volk area centralis. So the first step we would use is to titrate the power, and under micropulse or subliminal mode, we determine the thermal threshold by increasing the power level until reaching a barely visible endpoint. Then we reduce that power to 50% of the power. Everything is done under micropulse mode, and then we use the multi-spot delivery mode to implement the micropulse or subliminal treatment. So for example, during the micropulse or subliminal treatment, no visible reaction must be observed, and there's no need to change the power with different degrees of edema. The laser impacts must be confluent. Therefore, again, it is very important to have a multi-spot technology available. When we treat DME, we use an OCT guided treatment, whereas you use the OCT map and you treat all the thickened areas as seen in this example. Whereas for central serous chorioretinopathy, we use either ICG or fluorescein to guide our treatment. So in summary, the key characteristics of an ideal laser for macular work is one that is able to use these micropulse or subliminal mode, that it has multi-spot technology available, and that uses the yellow wavelength. Thank you very much for your attention.
We were going to answer the question that the panel discussed at the end, but all attendees feel free to type in your question in either the chat box or the Q&A box, but the chat box is probably preferred. And so the next talk is by Dr. Chhablani, and he's going to talk about the use of laser in central serous retinopathy.
Thank you so much for the great opportunity, and we really look forward to take this society forward, and hopefully we will be able to establish treatment guidelines using subthreshold laser. So today I'm just going to talk about subthreshold laser in central serous chorioretinopathy. These are my financial disclosures. So this is the agenda which I prepared for my talk, where we'll be starting with the CSR introduction, some of the management strategies. Then very importantly, we'll be talking about the photodynamic therapy, then subthreshold laser, and PDT versus microsecond laser. So what is CSR? We already know that it is one of the major causes for vision loss in middle-aged men. It presents with acute cases present with a subretinal fluid pocket at the center. Usually it resolves, but chronic cases does require some form of treatment. So this is a classification which was presented by Francine Behr-Cohen, where they were trying to divide CSR into acute, persistent, recurrent, chronic, and inactive. Now we have a new classification which we reported last year, is on the basis of a multimodal imaging. How do we image CSR? We all have been using fluorescein, OCT, ICGA, and fundus autofluorescence. And I'm not going into the detail of this, but these are some of the imaging modalities which are very important to grade the CSR severity, as well as to define what kind of treatment we are going to offer and follow up these patients. Let's move on to the next part of this talk, which is CSR management. And we all know that we have multiple things in our hand. For acute cases, we observe for 3 months, and then if they don't resolve, we offer them some form of treatment. These are the treatment options ranging from threshold, subthreshold laser, PDT, oral agents, surgical, and anti-VEGF therapy. But for today, we are just going to focus on 3 of these management strategies. One is PDT, threshold, and subthreshold laser. What is photodynamic therapy? The role of photodynamic therapy in CSR has not been proven in terms of animal models, but we believe that PDT leads to choriocapillaries hypoperfusion, which eventually leads to choroidal vascular remodeling, which leads to resolution of CSCR fluid, and it prevents the recurrence. This was clearly shown by one of the studies from China, which showed that if you can look at this circle in the right in the center, you are seeing that there is a dilation of choroidal vessels. And this patient underwent PDT, and you can see that how this choroidal vasculature has reduced in size, and this is how the patient resolved and the activity came down. So we know that PDT can lead to narrowing of the dilated and congested vessels. It reduces the choroidal vessel diameter. It reduces the choroidal vascular permeability, which is one of the most important pathogenesis proposed for CSCR. However, what is the evidence of PDT in CSCR? We all have been using for a really long time. It has its benefit. We use half fluence, half dose. However, we still do not know whether a half dose or half fluence is better for this treatment, but we do have some concern about the PDT. If you are repeating PDT, it might lead to a long-term RP damage. And one of the biggest challenge which we are facing nowadays is that PDT is not available in many countries, including India and in some parts of the US and in other parts in the world as well. So we certainly need another option which should be as effective as PDT and as less damaging as PDT. And as far as the cost is concerned, it should be lesser than PDT. So before we really jump onto the subthreshold laser, let's talk about what we have been using for many years, that is threshold laser. So Lihteh already discussed briefly about the subthreshold laser. I'll just take you through that. We have been using a continuous wave laser, which we call it as a threshold laser. We look for the visible endpoint, and that is a spot where we decide to do the treatment. However, we cannot offer this treatment if the patient has a subfoveal or a juxtafoveal leak because of the scarring, and if the patient has diffuse edema, which I'm sure the talk on DME, we will be discussing that. So let's talk about some of the benefits of threshold laser. You can just go ahead and do a single 1 or 2 spots where you really go and treat the laser's leaky spot, and the spot gets scarred and you get a resolution of the fluid. However, we use this laser pretty much for single leak spots, which are extrafoveal, but we cannot use for any subfoveal or juxtafoveal leakage in CSR. This is one of the example of focal subthreshold laser, where we are using Nevelas laser, where you can see that how the laser spot has been planned. And now while performing laser with the use of eye tracking, we can see that even if the patient is moving, the laser goes and hits exactly spot, as we can see on this video. This is another example where we can show you how the laser planning is being done using FA, and now the laser is being performed using eye tracking. There is no lens used for this focal laser application. These are some of the benefits of using Nevelas. Let's move on and talk about the subthreshold laser. What do we call it? There have been different terminologies for subthreshold laser: sublethal, subthermal, non-damaging photocoagulation, homeotropic laser treatment, subliminal, subvisible, and whatnot. The most common term which we use is the micropulse or the microsecond laser. The micropulse laser is used for the iridex subthreshold, and microsecond laser is used for the Nevelas subthreshold. What type of subthreshold lasers are present? You can have an infrared, yellow laser, endpoint management by Pascal, or now we have a nanosecond pulsing laser, which talks about SRT or 2SRT, where they have looked at AMD data using this laser. So I'm not getting into the details of principles of microsecond laser because Lihteh's talk clearly described, but this is a chopped beam which talks to thermal activation without causing any photoreceptor destruction. But more importantly, there have been some studies where they showed that there is a change in various biomarkers, particularly the heat shock protein, which changes after the subthreshold laser. And that is where the approach of subthreshold laser is useful. So what is the evidence for 577 nanometer microsecond laser? These are multiple studies where you can see that this laser has been used in CSR, and there is a definite benefit of using this laser in these multiple retrospective studies. However, we all face some challenges when we talk about the subthreshold laser, that there have been a variability in the parameter settings, the titration approach, and but the most common approach which people have been using is the 5% duty cycle with 200 millisecond packet with the 100 to 200 micron laser spot size. We usually start the titration using microsecond laser, and there have been a range of this deciding the threshold is around 25 to 50%. But I particularly use the 30% of the threshold, which I got by using microsecond laser. Let me show you some of my cases in last couple of years where I use microsecond laser, and we have had successful results in CSR. So this is a 49-year-old male who presented to me in December 2014, who came with a complaint of seeing central black spot in his left eye for last 2 months. He did not have any laser, he did not have any systemic illness. He was diagnosed as CSR, but they did not offer him any treatment, and he came for a second opinion. You can see that the right eye has 20/20 vision, left eye is 20/25. This is one of the really sad part about this disease, is that it leads to it may not lead to a real vision loss in terms of Snellen's chart, but you can see that the patient contrast and their near vision and their quality of vision is compromised significantly. So this is the OCT scan. The right eye has no fluid, left eye has subfoveal subretinal fluid, which is definitely the cause for his vision change. So we got his fluorescein using Navilas in those days in 2014, where you can see that the leakage is right in the center. And this is one of the reasons we cannot do a threshold laser, because we are certain that if you do the laser, a conventional continuous wave laser, you are going to cause scarring and he's going to lose vision. And this probably is the reason why he was not treated, though he had some symptoms. So we went ahead and did a subthreshold laser using 5% duty cycle, and he comes back in 2 months, and you can see that the fluid has completely gone. His visual acuity has improved from 2025 to 2020. I understand that it may not reach to a great quality 2020, but you can see that the fluid has resolved, which means that his visual acuity is and the contrast is improving. But the most important is that we probably have reduced the chances of recurrence in this eye. Show you another example of CSR, where the patient presented with both eyes diminution of vision for last 6 months. He had history of PDT in 2016, and he came to me with 2015 in his right eye, 2016 left eye. I'll just focus on the right eye, where you can see that his vision is 20/50, but the fluid is not much. You can see that there is a very shallow fluid, a shallow PD, which most of the time we believe that let's not do any treatment because the fluid is very shallow. But we have to understand that this persistent shallow fluid is the one which is going to cause further vision loss and the further quality loss. This is where we really need to treat this patient. So I got his fluorescein, and you can see that how diffuse hyperfluorescence and multiple leaks are noted, and you can see the late phases. This patient certainly deserves treatment to prevent further vision loss and hopefully complete resolution of fluid. So we got ICG. ICG confirmed the findings of CSR, where you can see a diffuse hyperfluorescence. And this is something very important. You will be able to see that how the larger area of the macular region is affected by using ICG. And this is where I decide my treatment, that yes, this patient certainly needs treatment. So we went ahead and did the subthreshold laser using 5% duty cycle. I usually paint almost all the areas of the leakage. And here you can see that how this patient has responded so well, and there is a complete resolution of fluid, and there is a slight improvement of vision as well. And we are hoping that this patient should remain dry. So let's move on to one of the most important part of this session, which is comparing PDT versus microsecond laser. So this is one of the tables which I made just to show you all that what all studies have been done to compare micropulse or PDT. So there are 4 studies so far. Compares which favors PDT is place study primarily, and favoring a microsecond pulse laser is pretty much in Pecors and Osmart and one of our paper long ago. So if you really look at the comparison, place study use half dose PDT, rest of the studies use half fluence PDT. We use yellow micropulse, place study use diode microsecond laser. And they did exclude subfoveal laser, but in many of the studies, we did include subfoveal fluid as well. Our study was the only study where we used navigated laser. The rest of the studies were non-navigated laser. And you can see that this is a table which talks about the overall comparison between PDT and microsecond or micropulse subthreshold laser. So we do understand PDT is an expensive, invasive procedure. It definitely comes with some side effects if you're repeating it many times. And pricing and availability is one of the biggest concern right now with PDT. In contrast, the subthreshold laser we have not reported any complications. I have been using subthreshold laser for almost now 5 to 6 years. The only disadvantage, or I would say the challenge, is that we have a very less literature available which compares randomized trials using microsecond or subthreshold laser. So with this, I would just summarize saying that microsecond pulsing laser is primarily just the chopped beam, which is leading to the efficacy which we want. We usually use a confluent laser covering almost all the leakage areas. Because you are using such a low duty cycle, you can cover more areas, particularly in chronic CSR cases. We usually titrate by using microsecond pulse laser, then cut down the power, the threshold power to almost 30%. We do have recurrences just because it does not lead to any structural damage. So we are pretty confident in repeating this laser while treating the CSR patient. With this, I would like to acknowledge LV Prasad, where I performed most of my work in India. And thank you so much for listening to me this morning. Thanks a lot.
Thank you so much, Jay. That's a wonderful presentation as usual. And more importantly, thank you, Jay, for getting up so early in the morning to join us. It's 6 o'clock in the morning in the US, and we are very grateful that you join us live. Our next speaker is Dr. Alejandro Filloy from Tarragona, Spain. And he's an expert on subthreshold laser as well. And he'll be talking about his experience using subthreshold laser for diabetic macular edema. Alejandro, please go ahead.
Hello, everyone. Good day, good afternoon for those of you in Singapore. It's a pleasure to be here in this inaugural webinar for the Subthreshold Ophthalmic Laser Society. And let's talk about subliminal laser or subthreshold laser for diabetic macular edema. Why, and also when and how. All right, first of all, why? I mean, unlike central ceros, in the case of diabetic macular edema, we have a huge variety of choices, quite widely available and quite proven to be effective. So in order to illustrate my point, I have made up this graphic. Do not look for any mathematical consistency of it. It's completely made up. I mean, first, I have related the anti-edema power, or the degree of edema you're facing in every situation, with the secondary effects at the cost of every option. Here, first of all, I have placed steroids, intravitreal steroids. I mean, I think cannot be much discussed that in case of a huge out of control edema, steroids are very usually the first option, and they are extremely powerful. They also come with a remarkable portfolio of secondary effects, cataract, glaucoma, and are usually the most costly option when talking about Ozurdex or Iluvien. Next would come the anti-VEGF, not quite as powerful as the steroids, but usually more affordable and without the associated secondary effects such as glaucoma or cataract, although they have their own portfolio of unusual secondary effects such as endophthalmitis. Here is where I would place subthreshold laser, a weaker option with the lowest level of secondary effects and cost. Not as effective as subthreshold laser and with a worse presentation regarding secondary effects is ETDRS laser. So in this scenario, why should we consider subthreshold? Well, that's because diabetic patients is a very complex kind of patient. It can present now very wide variety of scenarios. So sometimes not sometimes, in quite a large number of your patient, a weak laser treatment is a weak counts. Laser treatment is all you need to control him or her in a safe, effective, and efficient manner, thus saving him or her from costs and undesired secondary effects from other options that are not necessary for his or her degree of disease. Which diabetic patients benefit from subthreshold laser in my experience? Well, I'd say those presenting with an edema of inflammatory or exudative origin. I mean, without a relevant ischemic component. And those leads us with 3 scenarios, which I am going to illustrate with examples. First of all, the clinically significant extrafoveal macular edema. This edema, like in this case, threatening the fovea, with patients still preserving very good visual acuity. Still, in many parts of the world, many people would treat it with conventional laser instead of intravitreal drugs. Well, subthreshold laser offers an intermediate solution. You save the intravitreal drug, but you also save in the scarring and other secondary effects of conventional laser. Here we can see how the treated area improves. We have a thickening in a neighboring area. The patient remains diabetic, so edema appears here and there with the passage of time. I always like to use autofluorescence to check that there is no laser-induced damage. As you can see in this case, autofluorescence is impeccable, which would not be if we used conventional laser, those limiting the chance for further treatment in this area. One more example. Compared to intravitreal drugs, you have to be more patient with subthreshold laser. Those lights are separated 12 weeks and 12 more weeks, one single treatment at the beginning. Laser is slower, but is also usually more durable than the intravitreal treatment. As you can see in the treated area, in the left part of the OCT slide, the RP is perfectly continuous, zero damage, so you can treat it as needed in the future. This nearly foveal macular edema, as you can see, the edema recedes very nicely from the fovea, thus preserving the patient's good visual acuity. Retinography of the same case, where you can see how the vascular malformations and retinal exudates improve before, after treatment. Combination treatment following intravitreal injections. Some patients with an involved fovea, such as this one, which are already beginning to lose vision. In this patient, you don't want to lose time. You want to rescue, if you allow me the word, the fovea as soon as possible in order to preserve vision. We know that the longer the fovea remains bathed in this inflammatory soup, the worse the visual prognosis. So you inject, the idea here in combination treatment is to inject as necessary in order to rescue this fovea, improve visual acuity, and then consolidate your treatment with laser to obtain a durable response that decreases the need for further treatment. This is the most complex context because it's very patient-tailored. We do not have an inflammatory meter to know how much inflammation is in the background of this retina, so we cannot mathematically know from the start how many injections are going to be necessary to bring back this edema to the number of steps necessary to the point where it has become a case 1 scenario, so it will respond to laser. Laser is very operator dependent. The last case scenario my favorite is when the fovea is involved on the OCT, but vision is still good. This is a 20/20 patient, but the fovea is already anatomically, shows anatomical change related to edema. Well, intravitreal drugs is a difficult choice here. It's costly, patient will not feel an improvement, and of course, an endophthalmitis in a 20/20 is a disaster. You know, it's rare, but sometimes it happens. Conventional laser is not an option here. Well, subthreshold laser is. You can get the best of both worlds here with this nice anatomical restoration, one single treatment, and long-term stabilization. Slides are separated 12 weeks from each other, so we have a whole year here. One more case, more or less same history. Perfect or almost perfect vision, asymptomatic patient. You find this on the OCT. Subthreshold allows you to clear it. A wider edema. Usually you treat the area with a high enough number of spots, you will have no problem. Here, for example, I treated 360 around the fovea without treating the fovea itself, and it resolved nicely. Well, still a bit of thickening remaining at the end, but that's something you can live with compared with the first one. This is retinography. For this case, there's about 400 spots of laser here. I dare anyone to find them, to see them. We performed a small study in a series of patients, 23 eyes, if I remember well, in this situation, when in both fovea and good vision, we obtained a significant decrease of the thickness of central retinal thickness and resolution of edema in most of patients, while preserving this good visual acuity and no significant side effects. This is the conclusion of our results. If you're interested, the study is available on PubMed. It's an open access study, so you can download it readily. We conclude that subthreshold laser was effective and safe for this kind of patient when the fovea is involved, but vision is still preserved in DME. Apparently, sparing the fovea, something we like to do, doesn't worsen the results compared to previous studies, which is interesting to new practitioners. And compared to protocol V that suggests that observation is reasonable, we have to say that of the observation group on protocol V, the observed patient required a very strict follow-up, that 1/3 of them finally required at one moment of an injection to rescue them, 7 injections median around 2 years. And the protocol V did not use subthreshold laser in the comparison arm, just conventional laser. And by the way, the patients treated with conventional laser in protocol V also required less injections. Finally, how do we do? In this patient, we agree to treat them with subthreshold laser. How do we apply it? Well, Lihteh did most of the work for me here. We need to treat large areas to stimulate a number high enough of RPE and Mueller cells to obtain a clinically significant response. With subthreshold laser, cells become kind of molecule factories for you. You need to treat a lot of them. The power of a single cell is too little. You have to treat densely, avoid leaving blank spaces. That's why the automated delivery patterns are very useful, and to use the appropriate power, not use too much power per area, which will result in a subthreshold treatment with visible cell damage, which is undesirable and useless regarding our therapeutic goals. Remember, insufficient spots has been repeatedly identified as the #1 cause for treatment failure. Should we treat the fovea? Well, we have two correct answers to this. One is yes. If you know what you're doing, you can treat the fovea. Literature is on your side. The other correct answer is there is no need to treat the fovea. This scheme, I copied it from Victor. Let's suppose you want to treat this edematous area signaled by these exudates. You can treat this with this pattern. There's about 400 spots here, and you can decide to include the fovea or not. This is the difference between including the fovea or not. You will agree with me that those 8 spots will hardly make the difference when it comes to the results. So you can spare the fovea and still have good results and sleep better at night. The important is that you will still achieve good results because you will have treated a large enough area. Treatment guidelines. For DME, I use an OCT guide. The thickness map is very useful. It gives all the information you need. 5% duty cycle. I like to titrate power. The power I finally work with is usually between 300 and 400 milliwatts at 160 microns. I believe this to be an optimal spot size. 100 microns. Treatments take too long. Larger spots. If you miss on the spot, you leave large blank spaces. I use with these parameters the large areas centered at the peak of the thickened retina, which usually means from 150 to 700 spots. And I like to avoid foveal treatment. We need a little patience to wait 8, 12, or sometimes more in order to see results. I recommend to check autofluorescence when you begin to make sure you are not inducing RPE damage. Just few conclusion. Patient selection is key in diabetic macular edema. Every patient is his own world, so there is a need for tailored treatment, and that tailoring will come to you by experience. The cornerstone of successful treatment is always for subthreshold laser, and DME is not exception, surface area and density. Little bit of patient, you will have a earlier response in central serous, not as quick in DME. And of course, as with any surgical procedure, take note of your parameters, of your decisions, so you can audit yourself and your results and become the best laser surgeon you can. Thank you very much.
Thank you, Alejandro. That was very helpful. We're going to move on to the Q&A session now, and Jay is back with us. So if anyone in the audience would have any questions, please go ahead and type it in the Q&A session or chat box. But perhaps I'll start off by asking the first question to Jay. Jay, it's good that you share your experience with the Nebulas laser with us. You've also got experience using other types of subthreshold laser machines. And for the benefit of the audience, perhaps you could just share with us what are the different parameters you use, or are they the same, or how do you do it with the different machines?
Thanks, Ken. Important practical question, I think. So I have used Nebulas since 2010, and then they came up with the micropulse laser. So the overall experience with Nebulas has been for quite many years. I have used Iridex. The benefit of Nebulas I particularly use is that primarily for the documentation, because as Lihteh's talk, he was mentioning that we cannot see the visible burn. So in subthreshold laser, you really don't know where did you treat. So with the advantage of using Nebulas is that the area which you have done the laser, it can in their report, you can actually see the area which you treated. So that helps you to decide that, oh, I did treat this area, but the leakage is today somewhere else. So you understand that what you did was actually working. So other advantage of using Nebulas is that you can use the eye tracking. You really don't need the contact lens on the eye, and you can do a much closer, or you can vary the duration quite significant from 10 millisecond to 10,000, which we don't need that much variability, but these are some of the benefits of Nebulas. So the overall, my settings are, while treating CSR particularly, is usually 5% duty cycle, confluent burn, 30% of the threshold when the threshold was decided using subthreshold micropulse laser. And I usually treat almost all the leakage or the hyperfluorescent spots on the fluorescein. Yeah.
Thank you, Jay.
I have tried the Nebulas laser as well. I mean, it takes some getting used to because we are quite used to holding a contact lens over the patient. But I found that without the non-contact lens, when the patient blinks, the system, there's always a delay and a lag when they have to track back the position, and it's quite difficult for those patients who are blinking. And actually, the lens itself, although it's non-contact, it has to be very close to the patient's eye, and that also is a practical issue.
So some of the patients who are like really non-cooperative, who cannot fix it well, they do have a zero power lens, which you can put it just to give them the focus, or to give you a conventional feeling. So they do have a zero power lens as well.
Thank you.
Yeah,
sorry, Victor, go ahead. Yeah.
Yeah, Jay, I want to ask you a question about CSC, that, how when a patient come in, like some years ago, that we tend to wait for a few months before we consider treating patient. I mean, do you wait, or or you offer the treatment almost like right away?
Again, a very practical question. So These patients, we have been waiting conventionally for 2-3 months for the acute cases to resolve. But if the patient is very symptomatic, say they are one-eyed, they are not able to work, they are very symptomatic, their job is to look at the computers and now they are not able to do so much disability, then I might just offer them treatment right away. So I understand that we all have been waiting conventionally, and it is possible that you are doing the treatment, but it may just resolve on its own. But if it is going to hasten the resolution, why not? But it is all specific indications or the patient request I would offer at presentation.
And you also mentioned comparing micropulse and the PDT. And I mean, do you have a particular sequence? Will you say that try micropulse first, or if the patient can afford it, then try PDT first, or is there kind of particular management, methodology, you might say?
I'm sure most of you are aware that I practiced in India for almost 9 years, and then I moved to the US 2 years ago. So one of the challenge in India which I faced was that PDT was very expensive. So the most of the patients could not afford PDT. So I used to really offer micropulse as the first option, repeat it maybe 2 times and see how they are doing. And if they are not doing, then you are like not able to do anything other than PDT. However, in the US, PDT, it has, I mean, right now, we don't have a micropulse. It is yet to come, probably in a month or so. So I'm doing PDT right now here as the first choice. But one of the challenge of PDT in the US is that many of the states, the PDT is not available. So I do get a lot of referred cases where they cannot do PDT just because it is not available. So it's just mixed bag. When we are discussing with the patient, say you have both the things available, which one do you offer more? Then I would say sometimes micropulse is a good idea where you know that it's a much lesser damaging treatment option. So I would offer micropulse, because one of the concern with PDT is that if you have to repeat a couple of times, then you are always afraid about progressive RP atrophy, which I'm sure you are very concerned about as well.
Thank you. Alexandra, so you did mention about protocol V. So I think that protocol V, as I recall, is they can have observation, laser, and also starting anti-VEGF right away. And you did mention about that the laser arm require less injection. Can you? I know that it's not the main topic, but I wonder whether you can clarify that a little bit more. How would it affect your practice with knowing the protocol V result?
I'm sorry, I didn't get the last part of the question.
With the protocol V results, that it was suggested that you can wait until that the vision get worse before we start treatment, and they have including observation, but then also that they have the laser arm do actually less number of people in the laser arm require anti-VEGF therapy. And so with knowing those factors, that how would that affect your current management? So if you have a patient with central involved edema but still got good vision, how do you treat those patients?
Well, my first choice is still subthreshold laser. I mean, for those patients, I do not consider conventional laser. It's too close to the center, and conventional laser won't allow you to retreat many times over that area. The patient will remain diabetic for life. I do not really like to inject a 20/20 or 20/25 eye. I mean, I've got huge respect for that vision, and I don't want to think in the disaster of an endophthalmitis. Besides, of course, it's a short-term treatment and requires a very close follow-up. That's why I believe subthreshold laser is giving us the best of both worlds. Patient preserves its good vision thanks to a minimally invasive, minimally risky procedure with a good results that will probably last for months or even years. So I believe it to be completely superior in this particular context.
So also another practical question. So there might be someone that who have a slightly poor vision. So let's say now the patient have 20/40 and never been treated before, never had laser before, but never have injection before, and then obviously that the usual suggestion to improve the control, but still that then how do you approach the patient? Then do you give injection first, or do you give laser first, or do you do both at the same time, or what that you would manage the patient?
Yes, well, you need to investigate deep in this patient for example, in case that the edema, that vision, I can trace it only to the edema, and the edema has a clear source, you can think about starting with laser. But generally, these patients present a diffuse edema, so most of times I start with injections, both to obtain a quicker response and to evaluate the visual potential of that patient, to see how much does he or she see with its fovea dry, if you allow me the word. And then it is time to use laser to consolidate in order to space or even stop intravitreal treatment. And that's the real tricky part, when to move from intravitreal to laser. That depends on how much inflammation remains in the patient's retina background, which is not easy to estimate, right? So it requires a lot of experience, and still sometimes you miss. Still sometimes you always try to move to laser as soon as possible to save the patient's injections, but sometimes you move too early and the patient recurs, so you have to take a step back, go back to the intravitreal option and wait a little longer for laser.
So you mentioned in your talk that in diabetic, you tend to wait for about 3 months to retreat the laser, and you with a CSR that you might take faster to repeat. And I probably whether I ask Jay that question that if you have the first micropulse laser in CSR, how long do you wait to do the second treatment if it doesn't appear to respond?
Good question. So I usually wait for 2 to 3 months. If usually we have been conventionally waiting for 2 months, and honestly, we still have so much to learn about subthreshold laser. So I usually give them 2 to 3 months time and see that if there is a progressive regression, or if I'm seeing any change, may not be the complete resolution. Depending upon these things, we decide the next step. And if I see no change at 2 months, I will just go ahead and do the repeat subthreshold laser with the same settings.
Thank you very much. Well, I think that our time is right on time to finish. And, thank you for all those who attend the webinar. I think we were going to have more of this webinar and panel discussion in our website once we actually get all settled down. And you would be expecting our society website is expecting to launch later on in the year. But obviously that watch the space, and looking forward to see some of you again in the future. And again, thanks to our panelists and Sven, our speaker today. Thank you very much.
Thank you so much. Thanks. Thank you.
Yes, my pleasure.